All right, so we should be all set. Thanks.
So the first question is a long-acting injectable antipsychotic worth considering in a given case? So I took the example of a typical patient drawn from my own practice, and maybe you can all weigh in as to what you think, and we'll ask Dr. Condamarin to then tell us how he thinks about it, and and why he thinks about it, and so on. So this young man had racing thoughts, grandiosity, and paranoia, auditory hallucinations beginning about a year ago. He had one hospitalization about 1 year ago, diagnosed with bipolar with psychosis. He responded well to 44 milligrams of Risperdal. His symptoms had gotten better, but he still had a little bit of paranoia and ideas of reference in social situations. And whenever he missed taking meds or when he uses marijuana, which, by the way, he doesn't want to give up, he still occasionally uses weed in social situations. The last 1 month, his symptoms have gotten a little bit worse because he took a new job. And so he lost his job as a supervisor in a coffee shop. Now he is asking whether he should consider a different medicine. What are the questions that cross your mind? What are the options that you would consider in someone like this? Any of you, please give your opinion. Let me raise some options.
Yes.
Yeah.
Yeah. So,
Okay.
all right, I'll start by answering that this is a patient who obviously needs a long-acting injectable because when he starts getting symptoms, he doesn't recognize it enough to contact you and stops taking his medication. This is a very typical patient. And
Yeah.
also when they're on marijuana, they forget or they feel, maybe I won't take the medication and I'll use marijuana instead. So it's a problem. I would put him on a long acting and probably not change the medication since we know he responds to risperidone, probably go to Invega.
Okay. That's great. Other thoughts?
Okay.
Rahul, maybe you want to.
Yeah. I think it's the clinical cases very similar at the one we have it. No, this is bipolar with psychotic features, sometimes schizoaffective, but there is young guys who start taking the medication, and all of us, we feel better, and we believe we don't need to take it, no? And as usual, we don't take it for 2-3 days, and I feel good, and say, why I need to take it? If Kesh put a very scholarly, very well done in the 25s, so taking the people from the 18 to 30, not being in the middle, who is the people who have medication not adherence, poor medication not adherence, who is common, who are the people who are using weed on daily basis, people who are now summer hot are drinking a lot. Last week, and the purpose of this was asking some questions or so, and somebody told me, when you drink or you use drugs, don't go with medications.
Yeah.
So they know this weekend, so I stop. No big deal, no? And come back probably Tuesday a little bit because Monday I don't feel hangover, so I don't want to take it. And this become routine. So our levels, like a case have another slide, the levels are so erratic as it's nothing like this. No? Case presented like as an intelligent guy who is a manager, but he just at an early age and being smart and intelligent, he is already hospitalized, briefly but hospitalized. We don't know briefly because he needed just the medication, or he requested to be discharged MA, like is the routine, 3 days and they are out. No?
Yeah.
And this. Another thing important is like he's open to new medications. There is a bunch of good thought in the place. The thing is another mood stabilizer, so would be a good idea, but if they're difficult with one, to go with two is going to be even more difficult. Like it happened with our client who are prescribed 275 milligrams of clozapine. And sometimes they have 200 milligrams, 100, and 3 tablets of 25 because they don't have the 50 or so. So they consider like this 5 pills is too much. They want to just take 2. And they choose the little ones who are the 25. So they're taking like a 50. You know, it happened. They don't want to take the 5 tablet plus trazodone plus this plus that. No, they're not 25. Or like people tell us so many times, or they call your patient and not taking the medication for a while because they deliver the medication at 7 p.m. and the client do not show until 9:30 or 10 these days. No? So there is important, I want to leave it like this, like we need to discuss another options in that way, presenting what is real.
So your option would be the last one. Discuss all the options and get their input.
Correct.
Yeah. Other thoughts? Let me, put on the spot here the residents and fellows here. Megan, what do you think?
I would wonder cost disparity between the two medicines. I don't know how that works for you all. I just moved here, everyone from Kentucky, where I trained. We had a huge grant from Invega where we actually had these medications for free, and we used them first line for a lot of our patients. But I understand that in a lot of cases, especially a lot of the newer long-acting injectables are quite expensive.
Yeah. Great. Yeah. So Alexander, what do you think?
I'm very sympathetic to, I forgot the psychiatrist who, really pegged this person as an LAI candidate, but, I'd want to discuss the option with him and inquire a little bit more about his worsening symptoms, to the extent that there might be a mood component. Going right straight to an LAI might not be the first step I'd want to take. If there might be a psychological or a pharmacologic intervention in the form of an antidepressant, whether that be with therapy or with medication, might actually improve his adherence to the risperidone to begin with.
Great. Yeah, in fact, what I'm hearing from all of you is that none of those options here may be the best option. And the best option may be to find out more. Maybe there are some things we don't know about this patient.
Yeah.
Why is he showing these recurrent symptoms? Is it because of the non-compliance alone, non-adherence? Or is it because something else is happening in his life? Or is it because he has a mood syndrome that may require something else? Or whether he has a psychosis that is bound to relapse despite adherence, what is called a breakthrough relapse, which may require a different antipsychotic or different dose and so forth. So I think understanding the person better with all the potential factors that may have led to his symptomatic exacerbation would then give us the possible options. And again, as Dr. Kondamaran said, it's probably a good idea to, once we get a full picture, to discuss all of these options and get the patient's input. I think that's critical. And, it's shared decision making always works better. Get what the person might want and might prefer. My immediate reaction also would be like Dr. Delisi. I think this may be a good candidate for long-acting injectable, but he may not accept it. We have to be mindful of that. So I think if we have more information, we may have a way of selling the idea of a long-acting injectable. We'll come back to that point a bit later. Any other thoughts? Great. Okay, all right. Having made the decision, why long-acting injectables? And I don't want to throw too much data at you. It's like a real elephant in the room. We do know that relapse rates are lower with long-acting injectables compared to oral antipsychotics. The literature goes back a couple of decades now. So this is a paper that came in JAMA Psychiatry a few years ago, widely cited as one of the head-to-head comparisons of risperidone injections versus oral, showing a fairly stark difference. So the evidence is fairly good in terms of LAIs being better in terms of preventing relapses compared to oral antipsychotics. And also, there are several other advantages: better adherence, lower relapse rates, and because you don't have to worry about GI absorption and the variable first pass metabolism in the liver, it's a much more sure thing to give an injection. And also, patients tend to be more satisfied. Physicians tend to be more satisfied, and the outcomes are better. And also, this gives us an opportunity for patients to come regularly, in which case we can kind of combine psychosocial treatments in those visits along with the pharmacology. And also, if a person stops taking the injections, it's easier to detect. If it is only oral, we have to rely on what they say. That is always unreliable. And then there are disadvantages: the slow titration, the time that it takes to achieve steady state levels, reduced flexibility of dose adjustment, late appearing side effects, pain at the injection site, and also the idea that coming to the clinic on a monthly basis might itself be stigmatizing to some patients. Any thoughts or comments on this slide? And Dr. Kondamaran, with tremendous experience,
I wanted to add something to that.
Yeah. Yes.
Which is that family members often like the injections because they know that their loved one is getting their treatment because they take them there or whatever, and so that's sometimes useful, and sometimes patients like it because they know that their family knows, and so their family can leave them alone.
It's the reliability of knowing. It's the reliability of knowing that the person has received medication. That's a big factor. Yeah. Thanks.
I agree with Simon and with Kesh that I think it's later, Kesh put it in one of the slides, important to recruit more people as a part of this team, no? Family, the one who have family, case managers who can remind them and talk in different way like doctors. We talk, we could be more technical, no? And but this is so important. For instance, for some reason, our patient, I have here almost a mass mentor for almost 25 years, no? And at the beginning in the old building, they receive her check every 2 weeks. So almost close to 200 patients were there getting for their check, no? And when you enter the lobby, the old one, was a smell of popcorn. Was a lot of popcorn they were preparing for them. Was a kind of, and they took advantage to take a meeting for alcohol, because at that time weed was few, but was not too many drugs like we have now. But alcohol was the prevalent. So was different group, especially substance abuse, from night to noon, and then was good time for engagement through the talking to them, to knowing to them, to visit them, and so many improved at that time with the with the treatment for alcohol, with naltrexone or so. We didn't have at that time the injectable. But as Simon said, to involve more people is so important. Also, is very important after discussing with the client, no? Especially the one who are looking for something more effective, no? And as I always said, in a half hour, we need just 5 to 10 minutes for the prescription, and we need to engage the client. No, it's something. There is someone who, Austin Riggs, who wrote something about more psychodynamic psychopharmacology. And he always says it's not what we prescribe, it's how we prescribe. And Cage in the different slides put in the frame, no? I have empty, I have full, stuff like this, no? And two things, whatever we try to do it, explain clearly, listen, get something, and I think that we're failing in not believe where we do it. We believe we need to wait too much, and where we see fail, after 7-10 years, we try to offer something.
Yeah, wonderful. Thank you. So another advantage that is widely talked about in terms of long-acting injectables is that compared to oral, where there is this rapid climax of the blood levels and then a dip and repeatedly fluctuating blood levels, the long-acting injectables provide a more of a smooth steady state level, which might allow overall a lower dose to be required compared to the oral medications, and thereby the side effects could be kept to a little bit of a lower level. That's an advantage with long-acting injectables. So, how does one bring up, this patient that I showed has had a schizophrenia, a schizoaffective disorder like illness only for about a year. So when considering a long-acting injectable like that, Dr. Delisi said, which is a good idea to introduce a long-acting injectable for someone like that. But some other clinicians might say, isn't it too early? So the question is it okay? Is it a good idea or is not a good idea to bring an LAI early on? And maybe, we should have a discussion about that. So Lynn, if I may push you on this, does this make is it a factor you would consider how long the person has been ill? Would you go within the first few weeks itself or first few months?
Well, the first answer is yes. I would go in the first few weeks. So when I used to work on the inpatient unit, people would be surprised, but I would often offer the LAI to a patient. I mean, getting them first on the oral of the LAI, so you can make sure that the patient tolerates it, is very important. You don't want to just give them an LAI that lasts a long time and they may not do well and have side effects. So you have to take that into account. But yeah, I mean, I think they have a better chance for recovery from a first episode, which is really crucial. The first year after a first episode, you want to get someone back to recovery quickly. And if they don't take their medication regularly, and it is so common in a first episode clinic for a patient and even their family members to say, oh, he's well now. Why bother taking the medicine? If you have pneumonia, you take an antibiotic and you stop, you only take it for 10 days and then you're well and don't have to take it anymore. So it's very hard to convince these young people to stay on the medication, yet you know that you don't want to get them off of it for at least a year after they've recovered. So anyway, I do it very early.
So let me push you and the others a little bit further on it. And I completely agree with you about your approach. But the question is, we are talking about a first episode psychosis patient whose outcome is likely to be quite heterogeneous. And we know that, at least a small but significant portion of the population may not have more than a first psychotic episode. Why commit someone who may just have a brief schizophreniform disorder, which may not go into schizophrenia, or a brief psychotic disorder? Why commit someone like that into an injectable, then which might make it difficult to know whether the person's good outcome is simply because it's a good outcome psychosis versus whether it is due to the medicine that they're doing better. So I would be a little bit unsure, and which is why I might wait a little bit longer.
Well,
What do other
Cash,
people think?
look at the statistics. I think it's even up to, John Kane's studies have shown 95% of people with a first episode psychosis that's not due to, physical things, have relapse if they're off of medication. So statistically, I would keep someone on it without any symptoms for a year, and then take them off of the long-acting injectables slowly. So go down in dose and do it slowly, and see if they ever have an episode again. In many cases, they will. In fact, Simon can tell you about a case we had who didn't have any symptoms, was a school teacher, and wanted to come off of the long-acting injectable. And I think, Simon, maybe you could say he was only on the very minimum dose too. And
yeah, he was on the lowest dose possible of Invega.
yeah, and then when he came off, and Simon, I mean, the other thing is you might want to talk about how you take them off of this, but Simon increased the interval between the injections. This guy became psychotic and had to be rehospitalized.
Yeah,
So,
really pretty quickly. It was interesting.
Yeah.
Within about a month.
yeah.
Within a month of discontinuation of the long acting?
Well, no, we reduced it from every 4 weeks to every 5 weeks. And after the second 5-week injection, he started to decompensate.
Yeah, that's very, very interesting. I use one thing that could be useful clinically. If it is a monthly injection of, let's say, paliperidone, if patients come and say, I feel a little rough on the edge in the last week of just before the next injection, that is a sign that that's a person really is at a risk of relapse. If you prolong the interval between injections too much. So I try not to, and I'd be interested in Raul's input on this as well. If we are reducing and discontinuing long-acting injectables, my preference would be to go the path of reducing the dose as opposed to prolonging the frequency. Raul, what do you think?
Yeah, it's very common. I think as Simon and Delcy said, sometimes we see the clients are improving or are complaining something. It could be a little side effects, but something very important is how many consecutive injectable medication they have it. No, the longer the better once, but it's still these medications depends on the amount have a period. It's like our check. We could do something for 2 weeks, a month, but more than that, we need to go back to work or something. It's like this. No, you can stretch, but not so much. It's the same when we are trying to put it back. People disappear for summertime or so. So we need to know. It's basically, for instance, for instance, for Trinza, after or for Invega Sustina Monsis, 4 weeks to 6 weeks, like we can put it back or not. No, or you put it some orally, you want to change it, but it's a little more. You need to supplement it. No, and sometimes in doubt, you or you notice it's only 40 days or just 41 days, but you notice something like a Kesh mentioned, with a good idea to supplement, the give it injection and put it the lowest dose possible, no, to maintain, because the level start decreasing so much. No, speaking about this, just in case we cannot mention this later, is one of the questions always is how to supplement, how to push the oral to injectable, or somebody who missed the Trinza 3 months, no, and missed 1 or 2 months, no. If we can say he missed 2 injections only, look like a no big deal, but in terms of months, it's 6 months, no. So how to do it? No, so in those cases, we need to figure it out, because this kind of Trinza or so is 3 months, and give it a little chance to have in the system, like 1 more month. So we can put it in injection and some oral medication. But if it's longer time, we need to give oral and more dose, no? And any change we need to do the oral to injectable, as Delcy mentioned initially, after getting the tolerability or the prior history. At this time, we are late always with client to give it LAA. So they try so many things. Probably we know that. No, and it's very common. They said years ago, verification, or you remember, people said, I am allergic to Haldol.
Yeah.
Because they call it the tremors, or they don't want an injection. They knew it, so they tell us in advance allergic. No, and we knew it was not allergic. But just always, when you want to transfer to the others, no, you need to find, like Simon said, the lowest dose of paliperidone is you want to go the injectable to oral, you get also the lower dose, like a 3 milligrams. No, and like this. The higher dose, you want to use injectable, but the higher dose of oral could be 6 to 9 milligrams if you are AA2 or 1064. Something like that, just in general, because it's so many numbers, we don't remember well, but this is the idea, no? The shorter the time they elapse so they don't take it, we are there, no? With some supplementation and injectable. And I agree also, they offer the LIA and presented really well the advantage, the knowing the history. There's a 95% not adherence. They want to keep using wheat. I said, do your normal life. Okay, try to decrease a little bit the wheat. I know they were not going to do it, but take it, so they need to thinking, like, I'm taking this. I cannot take it this weekend because I want to use or I want to a party. No, I said, you do your life, you forget about it. You do this. Is the way I present it, the most positive reframe it.
Can I, Kesh, can I ask about Trinza? So you mentioned the Trinza, and first of all, when would you go to it? And do we know, is it as effective as Invega monthly injections?
Yes, according to literature, and Kesh know more than me this, it's very effective, not necessarily superior to monthly. The only thing is sometimes at the beginning, one of the goals was, because Kesh mentioned at the beginning, discuss it, and we get the goals and say, I want to start injection, but progressively, a couple of years ago, we said we have something on 3 months. Now we have something for 6 months. And later we can say we have once a year, probably. I hope so. And sometimes, hey, doc, when do you move me to the 6 months? So you started with injectable Vega Sustina for 4 months, and then you can move to the Trinza. No, you could be 1 month if you want, just 2 months to sit there, and then you go to High Fiera, and there is no big literature in terms of the Hypera because it's new, but it's comparable, not superior, but it's the same. The only good thing is the adherence like you have for 6 months, no? And it's good to explain to them how this works. And in between, as we discussed with Kesh before, it's idea like the client still coming to see you every 2-3 months. I talked to for this presentation, we have the Decanoic clinic for almost 25 years, 30 years in here, no? It started with the first generation, and it's good to have the same nurse doing this, so they know the person, no? They trust this person. They have a relationship. They go, hi, Michael, hi, Des. They come, Des. They know. Here, Reiki was telling me, like, she write it down what injection site is. Like, 2 days right, next month is left, and they can switch it. There are few who wants in the same place because they say, I'm righty, and I want to read, I want to eat because of the little pain. There is other people also they need to be explained. I have a couple of guys in Perseris who wanted to be out because they felt like a little bump in the stomach. And probably they missed the explanation, like when they come, mix it with more water, become like a little rock. No, rock, no, capsule. No, a little capsule, they can feel it. And that's after that they deliver. So I need to explain that, hey, you got like a little capsule and this open like sprays, something like this. But I need to tell them, otherwise they say, what is this? And the last consideration briefly is that we need to take advantage, guys, that we are in the time, like with COVID, people got more injections and become less afraid. 2, now, especially in women's, because of the metabolic profiles, everybody's placed more in Ozempic, Manjaro, so many things. I am taking this door open a little bit to put me. I said, you got your Ozempic, what day? This, okay. Take your Ozempic and I do my injection this. Monthly.
So you see this as an advantage. When they come for their monthly injection, you can combine that with their Ozempic injections.
Correct. Even though, people are not in advantage, the alcohol issues, they got Vivitrol in here and this, and they are fine. No? Vivitrol and I don't go much with olanzapine. The truth I mentioned to you guys because I didn't have the issues. People got used to it a little bit, but they don't comply with the 3 hours. So what's tough? Better don't touch this. I don't want to scare the other people because people come and sit down. If someone doesn't feel good, then can be a big issue. Sorry for
In
speaking.
fact, in this meeting a few months ago, I brought up a case that I was involved in consulting of a woman who did not believe she has schizophrenia and had completely no insight. And she agreed when she developed diabetes. Her husband was giving her the medicine antipsychotic in her orange juice. She developed diabetes, and then she saw an endocrinologist who was very friendly with the psychiatry team. And so he got her agreed to taking Ozempic injections to address the diabetes. But then, he was, so smart, and the communication with the psychiatrist was so good that he was able to convince the patient that, see, look, if you take this other injection as well, along with the Ozempic, you may be less likely to keep getting admitted to hospitals, psychiatric hospitals. So he combined the Ozempic with the Sustana injections, and then we have
Yeah.
problem after that. So
Yeah.
I have a question. This is anecdotal, but I was wondering if it was y'all's experience as well. But I've hospitalized a lot of people on Trinza and Hafyera who their injection does not last the advertised time of efficacy. Usually it's around anywhere from like 8 to 10 weeks as opposed to 3 months for Trinza. Has that been your all's experience? Obviously, I know that's anecdotal, so it's not true scientific evidence, but I was just curious.
I think Rahul was kind of alluding to that situation. it's always good to keep an eye on the patient. And if the patient appears rough on the edge in the 3rd month of Atrenza, start oral supplementation. That will give you the clue to shorten the frequency, from 3 months to 2 months or something like that.
Gotcha. Thank you.
Yeah.
Sometimes we saw this because the doesn't could be several things, no? If there are issues with the presentation could be a little worse because they're more active substance abusers. So the paranoia, especially, I think a case presented at the very beginning years ago, the use of marijuana affecting, because the marijuana, I'm not using, but it was totally different like 5 years ago. Sounds like it's too strong now, and people getting more psychosis or so. There's a factor, but I think the main thing is the time to pass to Trinza, we are using a lower dose. Sometimes if we set we're gonna give it, just want to start slow with 410. It's not enough, no? 410 is equivalent at 6 milligrams, no, 3 milligrams. So it's not, because it's gonna be 3 months, no? So it's better, probably could be one of the factors. Sometimes they need something more is going on, no? But if you move it to Trinza, if you take a consecutive injection and the higher dose, like A19, for instance, no? Probably this kind of psychosis could be a little less. But even though thing happens. Remember, there is things like we don't think about it sometimes, but they use those work in the cytochrome system, 2D6 and 3A4. And sometimes they do have inducer, 2D6 inducer. People use fluoxetine, paroxetine often. They use cimetidine over the counter. They take benzodiazepines to affect the 3A4, and sometimes, or people are poor metabolizers, and you give a 410, a poor metabolizer, we don't know, or it's taking fluoxetine for OCD or something, 120. Your 410 becoming like a 250. So in other words, it's like when I say the patient, you are working, but I'm making like a $3 a day. It's nothing. Okay?
So I have a question. Are these long-acting injectable predisposed patients to D2 hypersensitivity, supersensitivity? Because they are constantly in the blood system, so that it will cause more tardive or more, I mean, it will induce psychosis over the time because it's constantly in the blood system, and it will hypersensitive the D2 receptors.
The one who could hit better, more specific, the D2 receptor is Abilify. No, that is the reason who one of the side effects are restlessness, tremors, no, inner restlessness. It's more with Abilify, but Abilify is a dual, no? They have a agonist of DOPA and antagonist too. That is the reason we use for major depression or so. So it's like I always say, it's decaf and CAF. 70%.
Yes, but over the time, sorry, but over the time, the receptors auto-regulate themselves because there are a chronic suppression of D2. So that how can we prevent these side effects for them?
Well, I have a thought. This is a good question, Pega. Why does D2 hypersensitivity develop? It develops whenever the dopamine blocker, which is blocking the dopamine receptors, is taken away for periods of time. The remaining receptors become more hungry to utilize the remaining existing endogenous dopamine, which is why they become hypersensitive. So the more the chances of blood levels of antipsychotics, D2 blockers going down, the higher the chance of developing dopaminergic supersensitivity. Now, long-acting injectables may have a little bit of a protected advantage because the chance of them, not adhering to medicines and thereby having drops in their antipsychotic blood levels is lower with long-acting injectables. And so the opportunities to develop supersensitivity are lower. So, which
So
is
it
why
means that
you don't see the so-called
Mhm.
supersensitivity psychosis as often with long-acting injectables as you would with oral antipsychotics.
So you mean that it must be a drop in the drug level so that the
In other words,
receptor.
just to put it another way, oral patients on oral antipsychotics, especially if they are taking it only intermittently,
Mhm.
have a higher chance of developing recurrent dopaminergic supersensitivity and what is called breakthrough psychosis as a result of that, compared to those who are in a steady state of an antipsychotic drug.
And another question, is this long-acting injectable and more effective than oral agents in first episode psychosis for relapse prevention?
Well, the data are thin, but I'll show you one slide. Here is the slide. This is probably the only comparison of oral versus long-acting injectables, John Kane, 2020, who showed that long-acting injectables were better than oral maintenance in terms of survival without relapse over a almost 3-year period of time. So, which makes a good case for using long-acting injectables early on itself. So before we move on to the next topic, I just want to make one point here, which is in this large study by John Kane, again, only 4% of people in the early course of psychosis were on a long-acting injectable. So suggesting a marked underutilization of long-acting injectables. As we saw, in the patient that I described, which is a very typical classic case, the gut reaction for many of us, like Dr. Delisi articulated, was to go with an LAI. But what happens in practice? Very few actually get onto antipsychotic. There are many reasons for that, including patient factors, clinician factors, and also the the patterns, the systemic factors. The clinic may not be equipped with the injection infrastructure. So that may be more often the case for not using LAIs compared to many other factors that may be a big factor. And the other important thing is the doctors themselves may be ambivalent, which is quite often the case for not using LAIs early on itself. So let's move on to, which LAI? I mean, again, you all know this. I just want to show this in a simple slide. We choose which LAI for which patient based on what side effect you want to avoid, such as, for example, if the cardiometabolic parameters were a problem, you would want to use, something like aripiprazole, more likely than the others. And definitely you don't want to use olanzapine if that is the problem. For prolactin problems, again, Abilify Maintainer might be a better option. If you want something to work fast without an oral supplementation, you would go with olanzapine and paliperidone. Risperidone would require an oral supplementation in the first few weeks. And of course, there are also the options of longer time intervals between injection intervals available for paliperidone, which has Trinza and Harfera, and aripiprazole, which has the once in 2 months aripiprazole Aristada-like options. Of course, cost is an issue, and the older medicines still have a place, even though not common. Haloperidol, flufenazine, and so on. Any thoughts on this?
Yeah, as you said correctly, we use it often for people who develop, especially for some reason, we have a small sample of women's, not small, but many of the young African Americans develop hyperprolactinemia, no? And the levels around even higher, the 256 or so. 100 is considered, you need to rule out prolactinoma or something.
Yeah.
No, with level of 50, 60, even 70, we know it's induced by the medication. Sometimes we send it, working with the endocrinologist, we send it, sometimes they said it's not any issue related to the medication, and by transfer to aripiprazole, we see the changes. We
Yep.
see the changes, no? The second comment could be regarding to the olanzapine. We use not much the olanzapine. We use a lot olanzapine oral, which is really good, but we don't use too much the olanzapine injectable initially because, at least in my case, the first 3 clients I put it on olanzapine injectable, no one stayed for a 3 hours window. They need to be here. No, then some of them reported a little sedation or something. And one important thing about this syndrome is like even though people can get this delirium, severe sedation, some people could be in coma or something, the treatment is maintenance only. Then could be hospitalized, could be at home, because it start decreasing 24 hours or 72 hours disappear. They don't need to get more olanzapine because was enough a little small sample to get into the bloodstream to induce these symptoms.
Yeah.
No, so we don't need to. After this, what is the question is like, do I need to put another one or oral? No, it's gonna do the job.
Yeah. So another thing, is a practical consideration is some of them need to be kept in a refrigerator at minus 20 degrees and so on. Aripiprazole is one of them, and risperidone is the other. But paliperidone is okay, and the others are okay. Can be kept at room temperature. And I'll skip this one. And you all know about the place where to give the injection, the upper lateral quadrant of the buttock, or the deltoid below the acromion. And then there is the Z technique of giving the injection. I won't go into all of these details. And, this is something that I've been thinking about how to talk to patients about injections. And this generally applies to everything. Being humble about, the various options that are available. Medication is not the only option. Psychotherapy is very important. Being honest about the diagnosis and the relapse rates with the patients up front, and then present multiple options early itself, so that if you have a situation where an LAI is needed down the road, it should not come as a new news to them, that they have already been primed to the idea. And also, Rahul pointed out the importance of positive framing, and I'll show that with an example a little bit down the road, providing empowerment and shared decision making. And a negative framing could be like, based on your diagnosis and your symptoms, you have a 50% chance of relapses and being unable to work or finish school in the next 2 years. And our job is to prevent relapses, to do our best to prevent relapse. But the same thing could be said in another way, and that is based on your strengths and abilities, such as your good cognition and your treatment adherence. You have a 50% chance of being relapse free and return to your goals. Our job is to preserve your strengths and to even empower you. So present the same thing, but in a half full glass kind of way, as opposed to half empty kind of the glass. This is called positive framing. Any thoughts on that?
Yeah, the positive framing is so important, Kesh, no? And also knowing the client or I am 20, 30 years older than the younger guys, but for instance, they like to talk about rap or so. So before the day, I asked my son, who are the rappers? Who is this? I know Dr. Dre, 50 Cent, but they're too old. So I asked him for the new ones. So I talk and engage. No, there are few who like to write something. I give a letter, they can go to Berkeley or do something. They got an injectable now, they feel happy. Something like this, how to engage them. It's not only the medication, no? The other guy is tall and like basketball. We talk about the basketball and then we end up in the injection very clearly. The possibility, I say, I want you to see your potential. Don't be you like it to be more active. It's things like this, trying to be in the positive, but you need to try to know your client, no?
Yeah.
Even though 1 month, 1 more month, but we do the job. But the idea is like they keep it in there.
Yeah. Thank you. I
Yeah.
think we are at the end of our time. Any last minute comments or questions?
Kesh, I just want to say one thing. I agree with you about the positive attitude, but 50% sounds low, no matter how positive you are. Can't you say you have a better chance than 50%?
Yeah. Oh, that is based on, yeah, you're absolutely right. I mean, that was only as an example I put it in.
Okay.
Yeah. Okay.
Yeah.
All right. Thank you all very much. This was a very
Thank you.
lively discussion, and
Thank you, guys. Thank you.
have a good rest of the day, and we'll see you in a month.
Thank you.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you, guys.
Can you share the slides with us,
Absolutely. Yeah.
Kesh?
Yeah.
Yeah,
That would
yeah,
be
we'll put
great.
these up with the recording.
Yeah.
Great.
Yeah. We can share the
Fantastic. Thank
recording
you.
as well. Yeah.
Okay.
And also